You think of high blood pressure, you automatically jump to the heart. And while that is the most important part of all of this, it takes kind of a whole system approach, and it integrates looking at kidney function and maintaining kidney function, and also just, the body's metabolism as a whole. And also as it relates to cognitive function and brain health, which we'll see.
This is Generation Health. We bring you the latest news, cutting-edge research, and time-tested best practices, helping you live a longer, healthier life. Dante DiMatteo, PharmD, no cat in lap.
Catless.
How you doing, buddy?
Good. How are you?
I am fantastic. Microphone number 3, Josiah Schweinberg, engineer extraordinaire.
I'm also catless.
Yay!
For now.
Yeah, it's true. They like to make appearances periodically. That's why you got to watch. Or just listen, but we'll describe it to you. It's a white cat. It's fluffy. And it was in Dante's lap. Thank you. That is not if you do that in the middle of the episode.
I just want to know who thought that was the cat.
I did.
All right.
I thought it was the cat a second ago.
I was purring earlier. Now I'm making cat sounds.
Yeah.
You better watch out.
All right, Dante, we are talking about blood pressure, but not just blood pressure. The American Heart Association and the American College of I can never say it. American College of Cardiology, Hypertension put out brand new guidelines in 2025. I'm told this is big news.
It is.
I'm hoping you can explain to me why this is big news, because it sounds like, isn't this what they do every year?
Yeah. So it's definitely a healthcare worker bubble sort of phenomenon, So this isn't big news to everybody, admittedly, but it is big.
That's why we're here.
That's
helping
right.
Get the word out.
Yep. And that the guidelines, typically guidelines aren't changing every year. It's usually, 5, 10 years potentially. I guess it just depends on which you're talking about, but something like hypertension, which now, across the board, we've been treating for a long time, to make a big update like this, again, for something that we already are treating half decently. It's a big deal when they get updated, and when they get updated in such a way that, changes maybe some common practices for doctors, and then also has to change the way patients are thinking about this too.
That makes sense. So what is the big deal? I mean, so we've updated the things. Is it a couple points higher, a couple points lower? How do you want to peel this onion?
Yeah. So we're looking at, in this case, trying to understand the whole system of why hypertension occurs and why we treat it certain ways, why we want to treat it aggressively. And so in this case, maybe some of the guidelines in the past, or most people might be familiar with this as just more of a focus on the heart. You think of high blood pressure, you automatically jump to the heart. And while that is I think the most important part of all of this, it takes kind of a whole system approach, and it integrates, the importance of looking at kidney function and maintaining kidney function in the context of managing hypertension or preventing, and also just, the body's metabolism as a whole. And also as it relates to cognitive function and brain health, which we'll see. So it touches on multiple aspects, which is big. And then the kind of the headline that we're seeing with this change is the lower is better mantra. And so the old wait and see approach, which I think a lot of, maybe historically practitioners were a little more apprehensive to start different therapies, because patients were adamant about, I'm going to change this part of my lifestyle. I'm going to take out all of this extra salt that I'm eating. I'm going to, so on and so forth. So this is a much more, and it might make people uncomfortable, but this is a much more aggressive, I think. There's a more of an aggressiveness to these guidelines. Again, in terms of the lower we can get these numbers, the better. We're shifting towards earlier interventions than we already are. The goalposts really have just shifted because we're realizing that waiting until we see a 140 over 90 is kind of missing the boat. Mm-hmm. And then also we want to prevent heart failure. And again, like I mentioned, the importance of preventing cognitive decline to effect, as much as we can. And so how that all relates.
Okay. That's a lot.
Yeah.
We're playing footsie with all kinds of different ideas here. Cognitive decline, kidney function. Let's get specific. I thought, again, we're talking about the heart, right? Blood pressure, isn't that's the point? How are these things related? What is going on here?
Yeah. So for example, if we look at dementia, or if we look at cognitive function, this big shift is that hypertension or high blood pressure is the single biggest risk factor that we're aware of for cognitive decline. And so
kidding.
Yeah. And so the guidelines state that we need to get that top number below 130, ideally below 120, not just again to prevent, heart attacks,
strokes,
repeat attacks, strokes, etc., but also to protect the brain. So,
okay.
And I think it just crystallizes, a lot of what people are already concerned, what people are already being told. And now they have one more thing to connect this nebulous topic of cognitive decline to. Hey, if I'm taking care of my heart, if I'm a little more receptive to these recommendations and maybe this medication or this lifestyle change, that I'm also getting these downstream effects cognitively too.
That makes sense. Okay. It is always crazy every time we have conversations like this when I go, oh wow, it really is all connected. There's not, you can't really think of these things as compartmentalized, this organ's okay, but that organ needs some attention.
Yeah.
Yes, you can to some extent, but ultimately it is all interconnected. Every part affects every other part. Okay, cool. All right. So go ahead.
And what's interesting too, just understanding maybe some of the mechanistic side of the cognitive decline. And there's a whole, we could, riff on this for a long time, but if you think of it as higher pressure being present, it almost acts as like a power washer on the delicate vessels in the brain. So downstream effects of that, you can essentially cause these microvascular issues. We start to lose capillary density in certain parts of the brain, and then the brain eventually just starves of these nutrients, starves of oxygen.
Wow.
And then there's also kind of a cleansing or clearing pathway that occurs in the brain as well to get rid of certain waste products and such. And so because the vasculature in the brain stiffens and it becomes less elastic, more stressed, more inflamed, that some of that pump action fails. And what we see is the brain unable to clear some of these waste products that it normally can.
Okay. So go back. So what you said is that we think the relationship between high blood pressure and things like dementia, the brain issues, are related to the blood pressure being high means the blood is kind of functioning like a pressure washer. There's so much pressure coming through that it's damaging the really delicate veins in the brain to the point that they stop functioning. They just shut down or clot up or whatever.
Yep.
So that reduces the amount of oxygen and other nutrients getting to the brain over time. And then on top of that, that also reduces the amount of waste product cleaning that's happening to the brain.
Exactly.
Wow. Okay. I just want to make sure I got all that. Okay.
That's as good. That's as good as you could do it right there.
Oh,
I would say.
Thank you.
And there's more, there's even more to it there, but I think those are maybe like the 2 or 3 biggest aspects that hypertension affects.
So it is actually really relevant. Okay.
Yep.
So before we get into drugs, can we talk about what are good readings? You said lower is better. You said below 130, preferably below 120. How do we know all of this? Is this, should I just be looking at my wearable and see what my smartwatch says my blood pressure is? What are we doing?
Yeah. So as of right now, the frameworks for different classifications of hypertension more or less remain the same. Stage 1 hypertension is 130, the top number 130 to 139 over 80 to 89. And then stage 2 is considered anything greater than or equal to 140 over 90. And so even though those are the same, again, the imperative is that we've shifted towards earlier intervention. And if, for example, you find yourself in in stage 2, no matter what your history is, you're probably viewed as a candidate for more intensive therapies, as we'll get into.
Okay, those are the numbers. When we get that test done, I mean, I go to the doctor, I get my height and weight measured, and then they sit me in a chair and strap the thing on my arm and start pumping. It always kicks back a number. Well, I get my platelets. When I give platelets, I get my blood pressure done every single time.
Mm-hmm.
In the app, it's really fun. It shows you my blood pressure over time. 90% of the time, it's totally fine. Every once in a while, it's spiked really high over the 140, we'll say.
Right.
And it's a total rarity, but it happens. If that should be what happens when I go into my doctor's office, they're going to start being more aggressive about wanting to treat me even though I'm healthy?
Yeah, that brings about a really, really good question. In the short answer is, in order to be diagnosed, you first have to have an elevated office reading, and then you also have to prove that it's elevated in an ambulatory or a home setting. So you would either take, using a validated device, you would either measure this yourself, have somebody measure it, or be given some sort of validated wearable that can detect that. So rest assured, if you're giving platelets and you flag a high reading, it's not that you should ignore it. It's just that there are so many inputs that go into a proper reading. If you're think about giving platelets the way that you're sitting, you might be, flexing your abdomen a certain way. Your feet might be up. It's not a
running to get there.
Yes.
Probably listening to politics on the radio on the way in.
That's right. It's not conducive to a superb reading, we'll say.
Okay.
For the most part.
But it's not just a single office visit. They read it and now that's it. We're done.
Exactly.
There's more to the diagnosis.
Exactly. And even if you're with the individual who's getting you ready for the donation and they're talking to you, you're talking back. Talking can raise blood pressure up to 10, 15 points. So it is such a, for a lot of people, it's really such a, delicate balance. And so at this point, if you even go into your doctor's office, that's not even really viewed as a great opportunity to have that criteria met. You run in, you weigh yourself, you walk back to the office, you sit down, and then within 2-3 minutes, you've walked, 100 yards to get back there, and they're already taking the reading.
And I'm irritated because that scale just lied.
That's right.
Every single time. Okay.
Yeah. So there's there really is a kind of a whole process, more or less, to get somebody's, to get a proper reading, which we won't, I guess, get into fully. But we don't want the kind of the take home point here is one reading is noise. The average is the data that we want. The guidelines are prioritizing out of office monitoring. And so this is the ambulatory readings, as you might hear, or home readings. And we want to get that diagnosis not based on one stressful visit. We want to see over the course of over 24 hours or, an entire week, where do you fall in that spectrum? Because on the flip side, we might see, you see people like we mentioned who, if you're giving platelets, or if you go to your office and you have white coat syndrome, as I'm sure you've heard, and your reading is high, then that's actually not a bad thing. It just warrants a clinician to maybe investigate this a little further. The issue is something called masked hypertension. Okay. And if I could talk properly, that's where your blood pressure reading is normal at the doctor and then high at home. So if you go into the office and you find yourself, it's 121/80, and you're like, oh man, I'm good to go. In most cases, you usually are, but there are instances where this more kind of dangerous subsector of hypertension can occur. So
that's weird.
Yeah. So you want to, again, to drive home the point, in office or in clinic readings are really important. Or if you're at a pharmacy and they can take it for you, it's worth knowing it. It's minimally invasive. It's really easy for the most part. Yes. Some of these, devices are automatic. You can get it done there. But then also, it's maybe a good idea to use your your grandfather's or your parents' blood pressure cuff every now and then, or if you have one at home.
Okay.
And then the other thing is the device itself. So these are just, I think, really boring but practical things to make note of. If you are unsure if it's a good device, you can go on validatebp.org, and it goes through a whole list of cuffs and blood pressure monitor companies that are accurate, that have been tested and calibrated.
That's
and such.
cool.
So,
all right. Okay, so let's talk about what's changed, because a lot of what you just said, it seems like that's kind of standard operating procedure. We've got somebody who has slightly elevated blood pressure. In the past, the doctor would probably say, hey, eat less salt, come back in a year, we'll see what's going on. What's different now?
So the big difference now is actually in, like we mentioned, the calculator that's being used.
Okay.
So before we were using the pooled cohort equation, that was the standard for estimating 10-year ASCVD risk. The old formula, it was using older, less diverse cohorts. It was using, it was just a little more of a narrow path, more or less, to get this risk. Now we're looking at bigger. It's able to look at bigger swaths of the population. It can calculate your risk in somebody that's a little bit younger. Before, I believe it started at age 40. Now it's validated to look at somebody at age 30, which again kind of plays into this whole earlier is better, be aggressive as early as possible sort of mentality behind treatment. Also, it missed the boat on factoring in some of our kidney function values that are relevant to hypertension. So the key kind of with the kidneys, more or less, is it just helps to regulate fluid volume, and it produces certain hormones that then, can constrict or relax blood vessels. So it's a kind of a two-way street.
Okay.
If the kidneys are impaired, then you have kind of one less leg to stand on as far as managing your blood pressure. And then it kind of works on the flip side too. If your blood pressure is elevated over the long term, it puts undue stress on a lot of systems in the body, especially the kidneys. So it is an integral part to management. There are medications that mechanistically will work on the kidneys to help treat blood pressure. So if you kind of look at the whole cascade of things, again, it's not that before we didn't think the kidneys were important. It's just that they didn't have kind of their rightful place in factoring in somebody's risk. There's even metabolic markers. So we talked about the kidneys. So we're thinking more of the diabetes realm. And so it allows us to look at the A1C over time and how someone's blood sugar kind of plays into all of that. Social determinants thing too, I mentioned, it'll actually just use your zip code basically, as opposed to looking at race alone. It looks at zip code. You get a snapshot of of your demographic more or less, and that plays a role, especially in terms of the better way to put it is just looking at environmental stressors. And so these things influence outcomes. They influence adherence to medications and food supply and all those sorts of things.
So if I understand what you're saying,
just big changes to the calculator.
Yeah, the way the calculator works now is because it has so many other factors, it's not just looking at the direct reading of what was your blood pressure. It's also looking at all these other elements. Mm-hmm. And even if your blood pressure looks okay, or maybe a little elevated, if the other markers all along the way are in the danger territory, it's also going to flag you and drive changes.
Exactly.
Wow.
Exactly. So the number it'll spit out as a percentage. And so before, in the old equation, if it was equivalent or greater than 10%, that puts you at an increased risk. Now that number is the equivalent number in this new calculator would be 7.5. And so that's what they're So that's what they're looking at. This isn't the end all be all, but as of now, this is kind of the best way to, again, like I said, take all those things about yourself, where you live, all your biomarkers, put them into a calculator, and give everybody a framework to work from.
Okay, so we've got a situation, elevated blood pressure. The doctors are going to be more aggressive. what changes in the pharmacology realm? It's not like we have some new magic drugs or anything. Are they doing anything different there, or is it the same treatment?
So definitely a different approach here. And so this is one of the big points. If we just pretend first that if you're in stage 1 hypertension, so it's just above that cut point that we want to do something. So if it's
This is the
greater than 130, yeah. We want to, for the most part, I think that monotherapy will be employed. So a single agent could be used, or this is where maybe some more of the lifestyle things will come up. There's maybe a slightly less aggression here, but the biggest change is the classification of being greater than 140/90, let's say.
Okay.
So you're not being treated for anything. You come in, and this is the first time that we suspect you fall into this stage 2 category. We will often see dual therapy or 2 agents be employed at one time. And so for a lot of people, 2 medications at once is uncomfortable. It's too aggressive, and what about side effects? And I get that.
Yeah.
I definitely do get that. But in actuality, it is, knowing what we know now, I think the smartest way to approach this. And again, if we just back up a step, we think about hypertension being this thing that goes beyond just the heart beating and and it being related to this one pathway. It's being caused by this one thing. We know that we have this system-wide, this multifactorial disease that we're dealing with, in that, we have these certain pathways, and there are things in the kidney, and there's something called the renin-angiotensin-aldosterone system.
It's my favorite.
Yep. The sympathetic nervous system plays a role, kidney or renal volume retention. And so if we look at how all these medications work, they're hitting different pathways, and we don't always know 100% what the kind of the driving force is for somebody that's leading to them to this point.
Yeah. And
so if you think of it as maybe like hammering one pathway with one agent and maximizing the dose, what you can create a situation where the body, because it is complex and it adapts, it might change the way that one of these other pathways is working. And so you might see it's almost like they call it a compensatory counter regulation. So instead of it adapting for the good, it just adapts for worse in this case.
Some other element.
Yes, and that one element just continues to get worse. And so let's just say you use a diuretic, you use an ACE inhibitor, then now you're covering 2 bases and getting as far ahead of the game as you can. We're looking at addressing the kidneys, and then we're looking at reducing the amount of fluid that your body's holding on to, for example. And so it's just a way to even potentially reduce side effects, reduce toxicities of these agents, because you're going to be starting them at doses. You're going to have starting them at doses where you might have room to even go up. Whereas a lot of times someone starts on one agent, you start at a low dose, it's not working enough, then we increase the dose. Well, we can increase it again. And then next thing you know, you're maxed out. And I think that's at those higher levels are where you see people have issues, as opposed to a little bit of this one and a little bit of that one at these, what we know is like tolerable but effective dosing ranges.
Okay. So you just said by using 2 agents at once, we're having lower amounts of the drugs, but getting better effects, rather than having a single drug that we use a maximum dosage for and hope that that's getting what we want. Having multiple but lower doses is more effective.
Exactly.
And that's what they're recommending now?
Exactly.
Wow.
Yep. The benefits of combination therapy. And there's some research saying that the efficacy gets to approximately as high as 5 times greater using multiple agents, as opposed to just doubling the dose in monotherapy.
That's
great. So it's substantial. It's uncomfortable for some, but it is, it does work. And a lot of this, a lot of people probably, they're on 2 agents and they may not even notice, because a lot of these are single pill combinations. So you might see lisinopril and hydrochlorothiazide. Some people, they're like, well, it's one pill, it's one med. I don't know. My doctor put me on it. But really, you got two different mechanisms there. And so this is an age-old thing at this point that's been done. But now it's just we're jumping to this sooner than we were before.
Okay, so any other specifics about pharmacology that's changing here?
Yeah, since we have pharmacists here, we might as well
that is your
riff
job.
on some of the drugs real quick. There's not like a new class of medication being used to treat hypertension, although GLP-1s are now mentioned in the same guideline, of course.
Of course they are.
But
wow.
The old school, tried and true thiazide diuretics, hydrochlorothiazide, chlorthalidone, they've been around a long time. They essentially just make you excrete or pee out excess sodium. And we also have the ACE inhibitors and the angiotensin block, the ARBs, we'll call them, the ARBs. So that's lisinopril and losartan. These help to basically just relax the blood vessels. These have a protective effect on the kidneys. And then we also have calcium channel blockers like amlodipine, which can help, more or less prevent the calcium from causing issues in the artery. So that's just a quick and dirty kind of overview of those. They've been, again, there's 4 classes. Those are still the 4 most commonly used classes, except now if you're somebody who falls into class, category 2, you're probably going to see both of these.
You're going to see a couple of those.
One.
Okay. All right. So that's fantastic. Are there any major changes to the lifestyle modifications and suggestions? Of course, that's what we are generally known for. And we want to suggest that people make lifestyle modifications before medication is necessary. Anything new in that world? I don't want to take 2 pills. Help me avoid that.
Yeah. So a little more cut and dry here as well. There was the language in past guidelines and in past, I think health literature across the board was a little more receptive of some alcohol use. For example, it's harsh in this new guideline in that it says that the ideal amount of alcohol consumed is none.
Wow.
And so alcohol has a lot of not so ideal effects on the body. It can restrict, essentially cause your blood vessels to be more restricted when they should be relaxed. And gosh, we could go on forever with that. Also, they make a push for salt substitutes. We are looking at things like potassium enriched salt substitutes. There's, I don't even really know an example of some of the names.
Yeah,
but
fake salt.
Yeah, fake salt, basically. Which is interesting because I've never done that.
Yeah.
I've seen it. I've never actually done that or thought to do that. I think people mention that it tastes a little different, but the idea is to replace some of the sodium with some potassium instead. And that's an interesting one. Now there are instances where you will want to be careful if you are, because now we're looking at somebody who might, if they're adding potassium salt substitutes, they could be in a position where they're consuming too much potassium, and that's also not a good thing. If you're on spironolactone, or if you're on an ACE inhibitor and you're using one of these substitutes, there can be an issue just mechanistically.
Sure.
The way those drugs work. Those drugs can leave a little extra potassium in the blood than you normally would otherwise. And then, too much potassium makes the heart function all strangely. And we want to make sure, if you're on blood pressure meds, you check with us or you check with your doctor before making a hard pivot to one of these substitutes. But at the same time, we don't really think you should be loading your food with added stuff anyway. That's tons of condiments, that's tons of extra salt, tons of potassium rich fake salt. Doesn't really matter. I think you just want to use use your better judgment in how much you're adding to those too. And it's not even so much the added salt sometimes. Again, it's the processed foods that you might overlook that have a higher sodium content. And then you're also adding a bunch of salt to your home cooked meals
even when
too.
they don't taste salty to begin with.
Exactly.
Okay.
Exactly.
Wow, this is huge. These are big changes. We forgetting anything before we wrap up?
They're unfortunately not a ton in the way of supplements go, you know, in terms of what the guidelines mention, I think they're, like we just mentioned with the salt substitutes, potassium can have a blood pressure lowering effect. This is potassium mainly from foods, maybe a little less of effect from like supplemental potassium, but it can potentially reduce blood pressure. You just want to be really careful adding this to your regimen under your own
Make sure you're talking to your care provider.
Yeah. Yeah. And then, you know, some of our products have beetroot extract, things that enhance how, the function of nitric oxide, which can dilate blood vessels and have a downstream effect of lowered blood pressure. That anything that's fueling kind of the vasodilatory pathway, there are some supplements that do that, some amino acids that I don't think are going to be harmful, but this isn't one realm that's screaming for dietary supplements. It is more of a lifestyle modification. There are going to be some medications used. This is a tough one because a lot of times it's not something that you have overt control over, right? This isn't like necessarily a fully lifestyle driven thing.
Sure.
While it really has a strong component, there are some people that no matter what, once they hit a certain age or whatever the case, genetic predisposition to it, that it just sort of is what it is, and you want to get it addressed.
Past damage.
Yep.
Wow. All right.
Yep.
Well, not the sexiest topic in the world, but very, very important. Let me see if I got the takeaways. We're starting a treatment far more aggressively, far earlier. We're using multiple pharmacological agents instead of just trying to max out one. And really, this is not a joke. Please pay attention to it. It seems to be the punchline here.
Yep.
That's awesome.
Definitely.
I hope this helps.
They mentioned GLP-1s.
Of course.
Because of course, they don't just help you lose weight. They can even lower your blood pressure a little bit too. So
no kidding. I saw a study just the other day that was talking about increasing life expectancy for people with colorectal cancer.
Yep.
And it was, what don't those drugs do?
They are ubiquitous at this point in our discussions and in the pharmacy and
everywhere. Well, I hope that helped. If you or someone you know has been dealing with high blood pressure, they probably need to know these things, and they probably shouldn't wait until their next doctor's appointment to find out about them. More information sooner is better. So help us out, help your loved ones out, share this information with them, share the episode, give it a thumbs up or a like, leave a comment down below if you've got any questions. This is a big topic. We would love to answer your questions about it. Big thanks to everybody that makes this show happen. And if you also, I completely forgot our website. I should talk about our website. Dante mentioned the supplements we've got. We've got lots of supplements, not just for blood pressure, lots of fantastic supplements for other really substantial lifestyle altering situations. Go check out our website, askjoedimatteo.com. That's askjoedimatteo.com. You can also email us there if you've got a question. That's questions@askjoedimatteo.com. And I think that's it. I hope that helps. Thank you so much. We'll see you next time.